Let me know when to start.
Mr. Sumit, please.
Yes.
Just a moment. Dr. Fellini, please. I am stopping your screen share for now. After the introduction, you can start sharing again.
Should Sumit start?
Yes, Mr. Sumit, please. You can start in. I'll give you the count. 3, 2, 1. Please go ahead.
Good morning, eminent faculty members and participants who have joined us from various parts of India and abroad. I am Sumit Kumar Madan from Zydus Life Sciences Limited, and on behalf of Mumbai Hematology Group and Team Zydus, I welcome our keynote speaker for this Sunday's special academic feast, Professor Brunangelo Pollini, all discussants and participants to this virtual symposium on the update of classification of mature B-cell lymphomas in 2022. Before we commence the proceedings, I would like to welcome and introduce the host and the convener for this continuous medical education series under the aegis of Mumbai Hematology Group, Dr. M.B. Agarwal. Sir is Professor and Head Department of Hematology, Bombay Hospital Institute of Medical Sciences, Mumbai. He is also associated with other esteemed institutes as well, like B.D. Hinduja Hospital, Leelavati Hospital, Fortis Hospital, and Breach Candy Hospital in Mumbai. He is also the president of Mumbai Hematology Group. I request Dr. M.B. Agarwal to navigate this program further. Sir, over to you.
Thank you, Sumit. Good morning to one and all. Today, our guest speaker is Professor Fellini from Italy. He's going to speak to us on update 2022 of the classification of mature B-cell lymphomas. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus and managed by Perfect Square. I thank Mr. Ashish Kumar and his team from Zydus, Mr. Yash Kalpesh and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest today, Professor Amanjit Bal from PGI Chandigarh, our guest speaker, Professor Fellini from Italy, all our discussants who are themselves eminent hematopathologists, histopathologists, clinical hematologists, or medical oncologists. You participants for sparing your Sunday morning, afternoon, evening, depending upon which part of the globe you are from. We have today registrations from 27 countries to listen to Professor Fellini. This is the MHG website, www.mhgindia.com, and you can visit this. There is no password. It gives you all the information about our future academic activities, and there are past presentations also lying there. Just to introduce you to our next weekend activities. Next Saturday, 8th October, in the evening, 7 p.m. IST, we have Dr. Capecci speaking to us on thrombotic thrombocytopenic purpura. And then next Sunday morning at 11:30 a.m., we have Dr. Claire Harrison from London, UK, speaking to us about prognostic and protective markers for myeloproliferative neoplasms. Our discussants today are very, very important personalities from various parts of the country, and they are alphabetically listed here. I'll just introduce them to you briefly. We have Dr. Akshaya Mandloi from Kolkata, Dr. Amrita Saraf from New Delhi, Dr. Ashok Rajoria from Gwalior, Dr. Debadrita Ray from PGI Chandigarh, Dr. Devdeep De from TMC Kolkata, Dr. Gurmeet Singh from Bhilai, Dr. Jay Mehta from Mumbai, Dr. Jyoti Bajaj Saine from GCRI Ahmedabad, Dr. Parimal Sarda from Ahmedabad, Dr. Pulkit Rastogi from Chandigarh, Dr. Rajat Jain from Sahyadri, Pune, Dr. Rajini Priya Yedla from Vishakhapatnam, Dr. Sindhura Lakshmi from Manipal, Dr. Sundar Shevale from TMC Kolkata, Dr. Swasti Sinha from Lucknow, Dr. Tara Roshni Paul from Hyderabad, Brigadier Dr. Tathagata Chatterjee from Faridabad, Dr. Tulsi Giva from Vellore, Dr. Udyan Kachi from Vadodara. Now it's time to introduce our chief guest of the day, and that's Professor Amanjit Bal. She's MD DNB. She's Professor, Department of Histopathology at the prestigious PGI Chandigarh. She did her MBBS and MD in Pathology from Government Medical College, Patiala, DNB Pathology and Masters Molecular Pathology and Genomics from Barts Cancer Institute, London. Her research interests include pulmonary pathology, lymphomas, and breast pathology. She has over 300 publications in peer-reviewed journals and 11 chapters in books. She's principal investigator of 10 projects on cancer research funded by ICMR, DST, SERB. She's member of IAPM, IAPID, IASLC, and ISSLC, both international and national. She has received various awards, including Commonwealth Scholarship, V.R. Khanolkar Award for Best Published Research Paper. She was awarded 9th Dr. Reddy Lung Cancer Oration at ISSLC 2018 and Certificate of Excellence for Best Lung Cancer Care Team by IASLC 2019. I request her to inaugurate our today's webinar and give us some words of wisdom.
Good morning all, and thank you Professor Agarwal for having me as a part of this webinar on lymphomas. So as we all know that lymphomas have always been enigmatic and challenging for diagnosis also, as well as for managing them also. So as we see that lymphomas classifications, it has evolved over a period of time, initially from only histomorphology, then we had immunohistochemistry, which helped us at least in subcategorizing them, or what we say immunophenotyping of the lymphomas. But as we are gaining more molecular vision, now molecular subclassification is the in thing, and almost all the classifications of hematolymphoid lesions have a molecular subtyping now, which is an important or intrinsic part of each and every classification. Now, having said that, these molecular classifications have made our life much more difficult, so now the diagnosis of lymphoma has become much more complex and challenging. So as my younger colleague, Dr. Pulkit says that sometimes I feel lymphomas are like puzzles, but simultaneously he also enjoys cracking these type of puzzles, and he finds it very interesting. So even though these lymphoma classifications have become more complex, it's our duty of the pathologist to diagnose it correctly as well as subcategorize it, because it has both prognostic as well as therapeutic implications in the patient care. Now, with this evolving knowledge, how do we update ourselves? So for this, there is a need for these type of focused or targeting learning exercises, and such webinars which are being held by MHG group regularly are quite useful and enriching for these youngsters. So I have heard that they have been doing these webinars for so long, and they have already covered most of the aspects of hematology using these webinars. So as I said, that these webinars will motivate and they will encourage the youngsters to take the field of hematopathology or maybe hematology, especially for those, these will be important who are trying to join, or they are trying to look for which specialty they should join, or those who are young and in the initial years of in the field of hemato-oncology, hematopathology, or hematology. Having said this, sometimes people say that you cannot imbibe or learn everything from these webinars. But even if you learn 1 or 2 key points from these webinars, they are going to impact your practice, either a practice or a clinical practice in some way or other way. So today they have brought us Professor Fellini, who is a stalwart in a field of hematology and who will be briefing us on the update of mature B-cell lymphomas. So I'm really looking forward to hear to Professor Fellini, and I would like to thank Professor Agarwal once again to make me part of this learning exercise. Thank you very much.
Thank you so much, Professor Aman Jibal, for that wonderful speech. A lot of messages. Enjoyed listening to you. Thank you very much for sparing your time. It's now time for me to introduce Professor Fellini, our speaker of the day. So Professor Fellini has been our speaker in past as well. He has educated us in various aspects of hematology. He is director, Institute of Hematology and Bone Marrow Transplantation at University of Perugia, Italy. His main scientific achievements include pioneer work in the area of monoclonal antibodies and contributions to the development of the modern classification of lymphohematopoietic tumors. First immunotherapy with anti-CD30 immunotoxin in Hodgkin lymphoma, recognition of ALK-positive anaplastic large cell lymphoma as a distinct entity. His scientific achievements include molecular characterization of AML with normal cytogenetics, the discovery of NPM1 mutations and its translation in clinics, molecular characterization of hairy cell leukemia, the discovery of BRAF V600E as the underlying genetic lesion, development of new molecularly targeted therapies with BRAF V600E inhibitors in the refractory relapsed HCL. His research activities include he has authored over 350 peer-reviewed publications in internationally recognized journals, as well as several book chapters on lymphomas and leukemia. Moreover, he serves as a reviewer for major scientific journals. With H-index 94, Institute of Scientific Information, Philadelphia has listed him as a highly cited researcher in the field of clinical medicine. He is a member of the group 2003 that includes the most cited Italian scientists in different fields. He is a recipient of numerous research grants from several institutions, including the Italian Association for Cancer Research, the French Arc Foundation for Cancer Research, and the Hairy Cell Leukemia Foundation. He has been recipient of various prizes, the Jos Carreras Award 2010 from the European Hematology Association, which is the most prestigious prize in hematology in Europe, the Karl Lennart Lecture Award from the European Association of Hematopathology, Lisbon 2012, the Leopold Griffel Award 2014 from the French Association of Cancer Research, the leading prize for cancer research in Europe, the Gordo Venasta Prize 2014 from the Italian Federation for Cancer Research, the most important award for cancer research in Italy, and the Adolfo Ferrata Lecture Prize, Florence 2015 from the Italian Association of Hematology. He's a member of Scientific Committee, AIRC, ILSG International Lymphoma Study Group, the Clinical Advisory Committee for the WHO Classification of Lymphoid Tumors, Clinical Advisory Committee for the WHO Classification of Myeloid Neoplasms, Chicago, and the General Consensus Conference WHO Classification, Lyon, Clinical Advisory Committee for the WHO Classification of both lymphoid and myeloid neoplasms, Chicago. I invite him to deliver his lecture on Update 2022, the classification of mature B-cell lymphomas. Over to you, sir.
Dr. Fellini, you're on mute. Please unmute yourself. Your microphone is on mute. Please unmute.
Mute.
Yes, we can. Yes, we can hear you. Yeah.
Now we can you hear me now?
Yes, sir. You can go ahead.
Okay. Thank you very much, Dr. Agarwal, for your kind introduction, and thank you for the scientific committee to invite me to this webinar on updated classification of mature B-cell neoplasm. I will start my presentation today with a brief historical background. The different versions of the WHO classification during the past 2 decades are based on the principle defined in the revised European American classification of lymphoid neoplasms, named real classification, that our International Lymphoma Study Group published in 1994 in Blood. The real classification is a consensus list of lymphoid and myeloid neoplasm that pathologists can recognize with available techniques that obviously have dramatically evolved over the past 20 years, and they appear to be distinct clinical entities. This approach to the classification of lymphomas and myeloid neoplasm used at that time, it was early 90s, only available information, that is clinical data, morphology, immunophenotype, and when available, genetic features to define a distinct entity. The relative importance of each of these features varied among diseases, and there is actually no one gold standard. Morphology is always important, and some diseases are primarily defined by morphology, with immunophenotype as backup in difficult cases. Some diseases have a virtually specific immunophenotype or genetic alteration, such that one would hesitate to make the diagnosis without this information. Clinical information such as nodal versus extranodal, or the clinical presentation of certain tumors, especially T-cell lymphomas, for example, nasal type TNK lymphomas, is also critical for their recognition. As already said, the various version of WHO classification in ecco questo sì.
Aspetta.
Sì.
Qual è?
Questo?
Questo?
Sì, sì.
Oh, sta calmo,
Sorry, there was a technical problem. As already said, the various version of WHO classification in 2001, 2008, and 2016 were based on the principle established in the RIA classification. In order to ensure that every proposed WHO classification would be clinically useful, the steering committee invited expert hematologists and oncologists to form a clinical advisor committee with American and European co-chairs to review the proposed classification and advise the pathologist on its clinical utility. This is a meeting of the Clinical Advisory Committee at Early, Washington, D.C., before the WHO 2007. And this is the meeting of the Clinical Advisory Committee we had in Chicago before the WHO 2016. In each of these meetings, which was organized to answer to a series of clinical questions, a consensus was reached among clinicians in most of the questions posed, and a number of modifications to each proposed classification were made. WHO classification have represented for over 20 years the first true worldwide consensus classification of hematological malignancies. This year, for the first time, unfortunately, due to a number of reasons that are too long and difficult to explain, two different classifications were proposed that are named the International Consensus Classification, or ECC. This is based on the principle I have previously explained of the real classification, And I am a co-signer of the ICC classification. And the second classification, which is named fifth version of the WHO classification. The two classifications stratify hematological neoplasm according to lineage: myeloid, lymphoid, histiocytic dendritic cells, and mast cells. Today, I will focus my presentation to mature B-cell neoplasm. In each slide listing entities, I have indicated, as shown here, in one column, the terms of the WHO classification 2016 on the left, and in the other two columns, the changes in the ICC and the fifth edition of the WHO classification, respectively. This table shows the classification of small B-cell neoplasms and splenic B-cell lymphomas. The most important changes indicated in red and in blue regards B-cell prolymphocytic leukemia and hairy cell leukemia variant. In particular, the B-cell prolymphocytic leukemia that represent and distinct entity in the ICC, as well as hairy cell leukemia that represent a provisional entity, disappear in terms in the WHO classification of fifth edition, since in this classification they are absorbed in the basket category named splenic B-cell lymphoma with a prominent nucleolus. This category is very heterogeneous and includes also cases, as you can see here, of progressed B-cell chronic lymphocytic leukemia and of unrecognized leukemic mantle cell lymphomas. We decide to keep, however, B-cell prolymphocytic leukemia and hairy cell leukemia variant as distinct entity because their diagnostic criteria, if strictly applied, can allow to appropriately recognize these two entities. In particular, BPLL is characterized by marked lymphocytosis with more than 50% of prolymphocytes. The patient present with prominent splenomegaly in the absence of lymphadenopathy. In the bone marrow and the peripheral blood, there is a proliferation of medium-sized lymphoid cells which mature chromatin and single prominent central nucleolus. The cells have a B-cell phenotype with variable expression of CD5 and CD23 in about 20 to 30% of cases, and the tumor cell frequently carry a complex karyotype. Here you can see in these images the tumor cell with the prominent central nucleolus, and there is a bone marrow biopsies which shows a interstitial infiltration by B cells labeled by CD20 by immunoperoxidase technique. Hairy cell leukemia variant also represent distinct features that make to retain these distinct entity in international consensus classification that are here summarized. Usually, the morphology of hairy cell leukemia variant is at the border between B-cell prolymphocytic leukemia with evident nucleolus and hairy cell leukemia with prominent projection at the cell surface. These tumor cells are characteristically negative for BRAF V600E, which is the hallmark mutation in hairy cell leukemia. They are annesin A1 negative, which is also a specific marker for hairy cell leukemia. The sites involved by the disorder are spleen, bone marrow, and peripheral blood, but also lymph nodes. Characteristically, the patient present with leukocytosis, thrombocytopenia, anemia, and the presence of monocytes. This is a different situation from what you find in hairy cell leukemia, where monocytopenia is a characteristic finding. Unlike hairy cell leukemia that responds well to purine analogs, hairy cell leukemia variants responds only to combination of 2-CDA plus rituximab or bendamustine. Hairy cell leukemia variant also show unique molecular features. As you may know, classical hairy cell leukemia consistently harbor a mutation of BRAF gene. Conversely, about 40% of hairy cell leukemia variant carry mutation of the MAP2K1 gene that encodes for the MEK1 protein. Interestingly, this molecule is located downstream the BRAF protein in the MAP kinase pathway and is sensitive to MEK1 inhibitors. Both B prolymphocytic leukemia and hairy cell leukemia variant must be distinguished pathologically and clinically from splenic marginal zone lymphoma, whose main characteristics are here summarized. Most patients present with splenomegaly, splenic hilar lymph nodes without no peripheral lymphadenopathy. There are circulating villus lymphocytes where projection is characteristically polarized in these cells, and in about 30% of the patient, a small monoclonal spike, usually IgM, can be detected. As compared to hairy cell leukemia and hairy cell leukemia variant, splenic marginal zone lymphoma express at lower frequency CD25 and CD103. And in addition, does not carry the typical mutation of hairy cell leukemia, such as the BRAF V600 mutation or the MAP2K1 mutation typical of the hairy cell leukemia variant. This table, for your understanding, summarizes the genetic alteration observed in splenic B-cell lymphomas. As you can see here, the splenic marginal zone lymphoma is predominantly characterized by Notch2 mutation, whilst the hairy cell leukemia by BRAF mutation and the hairy cell leukemia variant by MAP2K1 mutation. There is another condition that can be distinguished especially from splenic marginal zone lymphoma and nodal marginal zone lymphoma, which is lymphoplasmacytic lymphoma Waldenstrom macroglobulinemia that carry another mutation, which the MYD88 mutations. So here I have summarized which are the relationship among the different classification between splenic B-cell lymphoma. So again, I'm going to repeat that the B prolymphocytic leukemia and hairy cell leukemia variant are distinct entities in the ICC 22 classification, while they are lumped into the term of splenic B-cell lymphoma with prominent nucleolus in the 5th edition of WHO classification. The other small B-cell lymphoma, in particular splenic red pulp lymphoma, hairy cell leukemia, and splenic marginal zone lymphoma are unchanged in the two classification. And here I have indicated which are the available target therapy for refractory relapsed splenic B-cell lymphoma, ibrutinib and venetoclax for B-cell prolymphocytic leukemia, BRAF inhibitors for hairy cell leukemia, and MEK inhibitor cometinib, for example, for hairy cell leukemia variant. Whilst there is no target therapy available for splenic marginal zone lymphoma at this moment, although this lymphoma responds very well to bendamustine. So moving to lymphoplasmacytic lymphoma monoclonal gammopathy of IgM type. Here I have summarized which are the classification of this condition. The WHO 5th edition give emphasis to the separation of lymphoplasmacytic lymphoma in two forms, IgM and non-IgM type, Waldenstrom macroglobulinemia. Unlike WHO 5th edition, the ICC recognize two forms of IgM monoclonal gammopathy, the so-called plasma cell type, the form not otherwise specified. Included in this family of diseases, I have also added the cold agglutinin disease that is now recognized as a distinct entity in both classification. The diagnostic criteria lymphoma have been refined in classification in that now lymphoplasmacytic lymphoma may be diagnosed when abnormal aggregates of clonal B cells and plasma cells are present, even if less than 10% of cellularity is represented. Whilst in WHO 16, the infiltrate must be more or equal to 10%. Confident diagnosis of lymphoplasmacytic lymphoma requires the demonstration of clonal B cell by flow cytometry, clonal plasma cell by immunohistochemistry, and abnormal aggregates in bone marrow trifine biopsy. This is a typical case of lymphoplasmacytic lymphoma. You see on the left a proliferation of cells which have a morphology which is intermediate between a lymphocyte and the plasma cells, with a round nucleus with mature chromatin and a white cytoplasm. And sometimes in lymphoplasmacytic lymphoma, you have the presence of Russell bodies, as you can see in this body, or Dutcher body, which are nuclear inclusion. This is the immunostaining of a bone marrow biopsy of lymphoplasmacytic lymphoma with a monoclonal antibody directed against the MAM1 IR4 protein that is expressed in some B-cell lymphomas and in plasma cells. And you see the plasma cells which are stained both in the cytoplasm in red and in the nucleus, because this is a transcription factors, whilst small lymphocyte and plasmacytoid B cells are negative for MAM1 IR4. This is a bone marrow smears showing a lower infiltration, but still sufficient to make diagnosis of lymphoplasmacytic lymphoma, cells with variable morphology, that is small lymphocyte, lymphocyte like this one, and frank obvious plasma cell like this element. So lymphoplasmacytic lymphoma is a mixture of small lymphocytes, lymphoplasmacytic lymphocytes, and plasma cells which are present at a variable percentage depending on the case, and these infiltrating cells are mixed with normal myeloid cells in this bone marrow. The MYD88 mutation is the hallmark genetic alteration, as already said, in lymphoplasmacytic lymphoma, Waldenström macroglobulinemia. MYD88 mutation is detected in more than 90% of cases, even in the cases of lymphoplasmacytic lymphoma who do not secrete IgM, for example, IgG or IgA lymphoplasmacytic lymphoma. The amino acid change at position 265 of leucine with proline is the most common exchange. The MYD88 mutation is absent usually in multiple myeloma and marginal zone lymphoma. MYD88 triggers tumor cell growth through Bruton tyrosine kinase activation, and another frequent mutation in Waldenström macroglobulinemia is CXCR4 that is observed in about 20% of cases and confers in vitro resistance to ibrutinib. And this is the hotspot of mutation in Waldenström macroglobulinemia at the level of the 265 position in the MYD88 protein and gene. As already said, the MYD88 mutations results into the constitutive activation of NK B cell, NF-κB, and B cell receptor signal pathways that can be targeted by specific drug such as ibrutinib. Interestingly, the response to ibrutinib correlates with the genetic alteration in Waldenström macroglobulinemia, specifically with the alteration of MYD88 in the CXCR4 gene. In fact, you have a mutation of MYD88 and CXCR4 is a wild type. You have the best response to in terms of decrease of immunoglobulin IgM level and increase of hemoglobin level. Because in this situation, you don't have the mutation 6 CR4, which is giving ibrutinib, and the excellent rational free survival, which is regression-free survival, which is obtained in Waldenström macroglobulinemia with ibrutinib. Search for MID88 mutation can be also useful in the differential diagnosis between lymphoplasmacytic lymphoma and nodal marginal zone lymphoma, because the marginal zone lymphoma is usually negative for MID88 mutation, whilst lymphoplasmacytic lymphoma is positive for this mutation. Another marker can be utilized for the differential diagnosis between lymphoplasmacytic lymphoma and the Waldenström macroglobulinemia is the search for the molecule which is called IRTA1. This molecule is expressed only in marginal zone lymphoma, whilst this molecule at immunohistochemistry is not expressed in lymphoplasmacytic lymphoma Waldenström macroglobulinemia. And this is an example of nodal marginal zone lymphoma immunostained for the IRTA1 molecule in red, whilst the B cell residual follicles, which are partially colonized by tumor cells in red, are negative. So this is a classical example of how you can recognize using IRTA1 molecule, which is a marker for marginal zone B cell, marginal zone lymphoma, and distinguish it from lymphoplasmacytic lymphoma. According to ICC, the different types of IgM monoclonal gammopathy are classified as follows. The IgM MAGAS of plasma cell type is characterized by the presence of the T1114 translocation between the locus of the heavy chain of the immunoglobulin and CCND1. Or the other myeloma-associated translocation at the locus of the immunoglobulin, or the presence of a clonal plasma cell without clonal B cells, and the lacking of MID88 mutation, which is typical of lymphoplasmacytic lymphoma. On the other hand, the monoclonal gammopathy of IgM type, not otherwise specified, does not correspond to this criteria, but correspond to the proliferation of clonal plasma cells and the lymphoplasmacytic cells, and at the lower percentage than 10%. And the two monoclonal gammopathies are different in that the IgM goose plasma cell type tend to transform into multiple myeloma of IgM type, while IgM MAGAS of not otherwise specified tends to transform to lymphoplasmacytic lymphoma. And then this is the characteristic of primary cold agglutinin disease, which is classified among the disorders which are usually associated with IgM paraproteinemia. And the characteristic of a primary cold agglutinin disease are here summarized. This disease is more frequent in colder countries. Usually is characterized by a proliferation of clonal B cells that sometimes can express CD5, but they are CD10 and CD23 negative. The mutation of MYD88, which is characteristic of aldosterone, are rare or absent. The primary cold agglutinin disease is characterized by frequent mutation in KMT2D and CARD11 genes, and trisomies of chromosome 3, 12, and 18 are observed. Then I'm going to move to marginal zone lymphoma that are separated in both classification in marginal zone lymphoma of extranodal type, that is multiple lymphoma, and nodal and splenic form. This separation, as well as their diagnostic criteria, remain unchanged in the two classifications. The most important change is the recognition of so-called primary cutaneous marginal zone lymphoma as a distinct entity. These are indicated in the WHO 5 classification and ICC with the two different colors, because in the ICC, this entity is defined as a lymphoproliferative disorder because of its indolent course, whilst in the WHO 5th edition classification is defined as lymphoma. Here are summarized the features of primary cutaneous marginal zone lymphoma or lymphoproliferative disorder, as you prefer. This is characterized by solitary asymptomatic pink papules on the trunk, arm and head neck area, or red-brown multifocal papules, plaque and nodules in the trunk and arms. This is usually associated with the Borrelia burgdorferi infection in Europe, but this association has not been detected in the United States. And there are immunologically two types of primary cutaneous marginal zone lymphoma, the so-called class switch type that express IgG or IgA, more than 80% of cases, and about 50% of these cases express IgG4. And in these more frequent cases, cutaneous relapse can occur, but survival is extremely good up to 20%. And the other condition is called as non-class switch that represent about 20%. The tumor cells express IgM. They resemble other multiple lymphomas, and they are more likely to have involvement at not skin sites as other multiple lymphomas. Here is the image of a typically primary cutaneous marginal zone lymphomas showing class switched IgG4 on the left, and on the with an infiltration of the subcutaneous tissues, and on the right of the so-called IgM positive primary cutaneous non-class switched marginal zone lymphoproliferative disorder. Unlike IgM positive cases, the form class switched are characteristically negative for the cytokine 6 CR3 marker, and they are negative for this marker. Classification of marginal zone lymphoma remains unchanged, whilst there are some changes in the category of follicular lymphomas. These follicular lymphomas include the recognition of two entities that are indicated in red in the ICC classification and in blue in the 5th edition of the WHO classification. These two entities are named BCR2 rearranged negative CD23 positive follicle center lymphoma, which is recognized as provisional entity in ICC, and is not considered an entity in the WHO 5th edition classification, and testicular follicular lymphomas, which is recognized as distinct entity in the ICC, but not considered an entity in the WHO classification, 5th edition. A more general issue is the grading of lymphomas. Sorry, the grading of lymphomas. So if you have, we have here the characteristic, summarize the characteristic of BCL2 rearranged negative CD23 positive follicle center lymphoma, which is recognized as distinct entity in the WHO classification. And these lymphomas is characterized by the presence of a large mass, usually in the inguinal region, although other lymph node sites can be involved, such as axilla and the neck. Another characteristic, as compared to other follicular lymphomas, is to have a family predominance. The proliferation in the BCL2 rearranged negative CD23 positive follicle center lymphoma, as you can see in these slides, is characteristically diffuse, although about 30% of cases can show a follicular type proliferation. Genetically, these tumors is rather characteristic because it presents with STAT2 mutations which are present in about 30% of cases. Gabri, dov'è la Gabriella? Oh, la condivisione dello schermo si è arrestata, vieni qua un po'. Porca Madonna, mi scorrevano a posto di 3 o 4, mi scorrevano. No. Devi andare via. Aspetta, no. Torna indietro, aspetta. Questa qui, sì. Ecco, questa apre.
Aspetta un attimo. Eccola, tieni. Questa?
Sì. Can you hear me?
Yes, sir. Yes, sir.
Yes, sir.
Okay, sorry, because the screen disappeared.
Yeah, okay, no issues.
Okay. Okay, here are summarized the characteristic of the other entity that is named among the follicular lymphomas as testicular follicular lymphoma. This is predominantly observed in children and teenagers. It is rarely reported in adults. It does not usually have a rearrangement of BCL2 at molecular diagnosis and is negative for BCL2 protein at immunohistochemistry, and it usually can be managed conservatively without chemotherapy. Here is the histological features of the testicular lymphoma. As you can see, is a follicular type proliferation, which is positive for all the B cell marker, including CD70A, as you can see here, but the tumor cells are negative for, characteristically negative for BCL2 and do not have rearrangement for the BCL2 gene. Now moving to diffuse to aggressive lymphoma, there are several considerations that should be done concerning this type of lymphoma. First of all, that translocation for MYC, BCL2 and BCL6 should be always searched to identify the high-grade B-cell lymphomas. That the cell of origin, the search for the cell of origin of diffuse large B-cell lymphoma, not otherwise specified, is maintained in the ICC classification, but is regarded as optional in the first edition of the WHO classification, and that the limitation of this binary classification according to the cell of origin should be recognized on the light of the high complexity of the molecular structures of diffuse large B-cell lymphoma that can carry up to 100 mutations. As you can see, in these slides that highlights the molecular complexity of diffuse large B-cell lymphomas that can be divided according to genetic lesion in several molecular categories that are defined by MYD88 and CD79B mutation, NOTCH1 mutation, TP53 inactivation aneuploidy, BCL6 translocation, NOTCH2 mutation, TET2 and SGK1 mutation, and other mutation involving AZH2, MYC, and TNF1P3 mutations. So each one of these group of molecularly defined diffuse large B-cell lymphoma may show a different prognostic curve when treated with the conventional chemotherapy. However, the Clinical Advisory Committee also finding that this information is extremely important for defining the biology of the diffuse large B-cell lymphoma. It was premature to incorporate all this molecular information in the present classification, waiting for additional data from this molecular study, and eventually to incorporate this information in future classification. A few new entities have been recognized among diffuse large B-cell lymphoma in both the two classifications, and they are named under different terms. One of these entity is called large B-cell lymphoma with 11q aberration, which is recognized as a provisional entity in ECC, and high-grade B-cell lymphoma with 11q aberration in the WHO 5th edition. And the other is the primary diffuse large B-cell lymphoma of the testis in the ICC classification, and the lymphoma of the immunoprivileged sites that include testis, vitreous retina, and CNS in the WHO 5th edition. Here I are summarized the characteristic of the diffuse large B-cell lymphoma, high-grade B-cell lymphoma with 11q aberration that has a wide spectrum of morphology ranging from large B-cell to blastoid type, intermediate type B-cells. It is characterized by peculiar starry sky macrophage. There is no MYC rearrangement unlike Burkitt lymphoma, and there are typical 11q aberrations detected by FISH. The mutational profile of this lymphoma is much closer to diffuse large B-cell lymphoma NOS for the presence of GNA 13 and CREB-P mutation, and rather than to Burkitt lymphoma. In fact, in this condition lack the typical ID3 and TCF3 mutation of Burkitt lymphoma. And this type of lymphoma with 11q aberration that characteristically occurs in children and young adults and is mostly nodal, is characterized by a favorable prognosis with current treatment. Here are summarized the characteristic of the other entity name primary diffuse large B-cell lymphoma testing according to ICC. This lymphoma has overlapping features with the primary lymphomas of CNS in terms of mutations of the BCR signaling pathways, such as those involved in CD79A. And these tumors, in fact, arise from an immunosuppressive macroenvironment, that is the testis, that allows development of gametocytes and provide an ideal milieu for growth of lymphoma. Most cases are of ABC subtype, that is express markers which are typical of cells which are exing from the germinal center or post-germinal center, such as MAM1-IR4 at immunohistochemistry. This type of lymphoma may involve the contralateral testis and CNS, and it is treated using chemotherapy plus prophylaxis for CNS involvement. I would like to remember that this primary diffuse large B-cell lymphoma testis is lumped in the WHO 5th edition classification in the group of the lymphomas of immunoprivileged sites, that also include a primary lymphoma of CNS and the vitreoretina. Here is the another question that rises during the international clinical consensus classification, is whether the same criteria we applied to classify the lymphoma of the testis and the central nervous system should be applied also for other extranodal diffuse large B-cell lymphomas of ABC type, rising from different sites, such as breast or adrenal, and this was the topic of a long discussion among the clinical advisory committee, that at the end concluded that at the time being there is not enough information to conclude that these lymphomas are homogeneous clinical entity, and one should recognize this group of lymphoma as deserving more specific studies, but at this moment not as distinct entities such as lymphomas of the testis and the CNS. This table shows the classification of high-grade B-cell lymphoma and the HCV8 associated lymphomas, and there have been two important changes in this regard. Their recognition as entity of lymphomas names double-hit lymphoma with MYC BCL2 rearrangement in both classification, ICC and WHO 5th edition, and moreover, the ICC classification, but not the WHO, recognize as a provisional entity also the so-called high-grade B-cell lymphoma rearranged for MYC and BCL6. Here are summarized the characteristics of MYC BCL2 double rearranged high-grade B-cell lymphomas, which shows a morphology range from large cells to blastoid intermediate cells, is of germinal center origin in 100% of cases, according to gene expression profiles It derives from centroblasts of the germinal center dark zone. Fish break-apart probes are recommended for diagnosis, but may miss up to 20% of cases which are cryptic. The mutational profiles is similar to aggressive follicular lymphoma with an arrangement of CREB-P, H8H2 mutations. And here are the characteristics of the other entity, a provisional entity in ACC, which is the high-grade B-cell lymphoma with MYC and BCL6 rearrangement. This is much more heterogeneous in cell origin and mutational profiling as compared to the entity characterized by the rearrangement of MYC and BCL2. And some cases shows the mutational profiling close to Burkitt lymphoma. And the third category, which was also present in the previous WHO classification, is so-called high-grade B-cell lymphoma, not otherwise specified, which is an exclusion diagnosis when the criteria for diagnosing cases with MYC, BCLC, and BCL2 rearrangement are not fulfilled. However, it should be reminded that these diagnoses should be done always with caution, because there is low reproducibility in the diagnosis of high-grade B-cell lymphoma not otherwise specified. How should we diagnose high-grade large B-cell lymphomas expressing TDT? In the previous WHO classification 2016, these cases were classified as lymphoblastic lymphoma. Now, both the ICC and the WHO 5th edition classification regard these lymphomas as high-grade or large B-cell lymphomas expressing TDT. And this decision in terms of classification to call these lymphomas rather large cell lymphomas or high-grade lymphomas rather than lymphoblastic lymphomas has clearly therapeutic implication. And this is an algorithm that helps to simplify the diagnosis of these lymphomas. So if you have morphology of Burkitt, microarrangement, you diagnose the cases as Burkitt lymphoma. If you have high-grade Burkitt line morphology, but you have not MYC rearrangement, and you have 11q aberration, you have large B-cell lymphoma with 11q aberrations. Otherwise, if you don't have rearrangement for, if you have a MYC and BCL2 or MYC and BCL6 arrangement, these are classified as high-grade B-cell lymphoma, double it, MYC, BCL2, MYC, BCL6. If you don't have these molecular characteristics, the tumor is classified as high-grade B-cell lymphoma, not otherwise specified. Now, I would like to conclude my presentation just discussing Hodgkin lymphoma and mediastinal grade zone lymphoma. There is one important change in Hodgkin lymphoma. Whilst the WHO 5th edition still consider nodular lymphocyte predominance as a subtype of Hodgkin lymphoma, the ICC terms this category of Hodgkin lymphoma as nodal lymphocyte predominance B-cell lymphoma. So it has moved this category from Hodgkin lymphoma to non-Hodgkin lymphoma. And the other category that I'm going to discuss is mediastinal gray zone lymphoma, which is correlated to primary mediastinal lymphomas and Hodgkin lymphoma. Here is the category of Hodgkin, predominant Hodgkin, lymphocyte predominant Hodgkin lymphoma, according to WHO. You can see that this category is different from classic Hodgkin lymphoma because of the morphology of the tumor cell and the consistent expression of B cell markers, whilst the B cell program is consistently downregulated in Hodgkin Rigber cells of classic Hodgkin lymphoma. This lymphocyte predominance Hodgkin lymphoma, but lymphocyte predominance B cell lymphoma in the ECC classification is characterized by a number of patterns, so-called grade 1 pattern A, B, C, a grade 2 pattern D, E, F, which are here represented. And the grade 1 pattern are usually associated with a less aggressive disease, whilst the grade 2 pattern are more resembling the so-called entity of T-cell rich, histiocyte rich B-cell lymphomas. And these cases are usually characterized by a lower infiltration by accompanying normal B cells, by a diffuse infiltration, and by a larger number of tumor cells. And interestingly, there are now clinical trials that show how lymphocyte predominant B cell lymphoma or lymphocyte predominant Hodgkin lymphoma, as is called in WHO classification, respond well to chemotherapy regimen using in Hodgkin lymphoma, such as RSOP lymphomas. Here is the summarize the features of mediastinal gray zone lymphoma, which is characterized as highlighted in green by a number of features that help to distinguish this condition from primary mediastinal B-cell lymphoma and classic Hodgkin lymphoma, with which there is a continuum in terms not only of morphology, but also of molecular features. So mediastinal gray zone lymphoma that are recognized as such in both classification are characteristically occurs in young adults with slight male predominance. There is a frequent mediastinal involvement with bulky disease. About 70% of cases shows a classical Hodgkin-like morphology resembling nodular sclerosis, Hodgkin lymphoma rich in tumor cells. The remainder cases mimic in terms of morphology primary mediastinal large B-cell lymphoma, and characteristically mediastinal gray zone lymphoma, unlike Hodgkin lymphoma, express more than one B-cell marker, that is CD20 in addition to 79A or another B-cell marker. Usually there is an overlapping of the molecular features of mediastinal gray zone lymphoma with the primary mediastinal large B-cell lymphoma and classical Hodgkin lymphoma. However, it's of fundamental importance clinically to separate mediastinal gray zone lymphoma to the other two entities, because these lymphoma have a poorer prognosis when treated with conventional chemotherapy and may require different regimens. Here is tables that helps to differentiate so-called grade zone lymphoma arising in the mediastinum from the cases which have the same immunophenotype and morphological features that arise outside the mediastinum. And these last lymphomas that arise outside the mediastinum are not recognized as an entity in the classifications. They, in fact, are more heterogeneous in terms of molecular and immunohistochemical features, and they should be classified, this gray zone arising outside the mediastinum, as diffuse large B-cell lymphoma, as not otherwise specified. So the true gray zone lymphoma are only those arising in the mediastinum according to Botter classification, and this overlapping of features with primary mediastinal lymphomas and Hodgkin lymphomas probably reflect the fact that gray zone lymphoma of the mediastinum rise from the same cell. There is the thymic B cells around the asar corpuscles that can give origin to these three different entities. These cases of non-mediastinal gray zone lymphoma, in which you have co-expression of CD30, CD20, CD79, but because this rises outside mediastinum, this is called diffuse large B-cell lymphoma, not otherwise specified. And this instead is a case of a true gray zone mediastinal B-cell lymphomas, in which you have expression of CD30, co-expression of CD20 and CD19, two markers arising in the mediastinum. And this is a true case of gray zone lymphoma of the mediastinum. And this is I will conclude saying that, as said in the introduction, there is an increasing use of molecular techniques for classifying lymphoma, this making the field more and more complicated. However, to conclude, we should, I have some, there is some open question that have raised by the two classification. So now, how should we report the cases? Now we have two classification. Probably for the time being, both the WHO 5th edition and ICC classification should be mentioned. And then I think that effort should be devoted in the next years to unify again the classification. These two classifications are not extremely different. I think there is a space to find again a common language. The last consideration is regarding developing countries. There are increasingly molecular-based classification, but we should not forget there are countries that cannot afford all these molecular studies. So I think efforts should be devoted to provide surrogate for molecular studies, that is to produce, for example, antibodies that can substitute molecular studies, such as the antibodies that we have now against ALK or NPM1 proteins that can allow to make diagnosis of genetic entities such as ALK-positive lymphomas on NPM1 mutated acute myeloid leukemia without molecular studies, but using immunohistochemistry. Thank you very much for your kind attention.
Thank you, Professor Fellini, for that wonderful talk. Just realized how inadequate our knowledge is and how complex the subject is. Thank you very much. So we have our colleagues here who will like to ask you some questions. So those
Yes.
of you who are, have questions, you can raise hand, open your video, and please put the questions. Meanwhile, there's a question from the audience. Dr. Sumit Mirg wants to know, sir, one thing. A high-grade morphology B cell type with MYC rearrangement only, BCL2 negative, BCL6 negative. How will you differentiate between Burkitt's versus single hit MYC rearranged high-grade B cell lymphoma?
Okay, so if you have a high-grade B cell lymphoma with only MYC rearrangement, this case, if you have the morphology and the mutational profile of Burkitt lymphoma, it should be classified as Burkitt lymphoma. If you if you have a large B cell lymphoma or high-grade B cell lymphoma with MYC rearrangement that does not fulfill the category of Burkitt lymphoma, this should be classified as not otherwise specified.
Okay, sir. Any questions from the, Dr. Pulkit?
Yeah. Hi, everyone. So I have a question, just a simple scenario that we face during the bone marrow reporting day to day. So my question is how to approach a case which presents basically with a primary bone marrow disease, primary bone marrow lymphomas. It doesn't have any evidence of extramedullary disease and the trephined biopsy showing just CD20 infiltrate. And on flow, they are CD5 negative, CD10 negative, and we do the common BRAF mutations mediated, which turns out to be negative. So does this entity exist, the primary bone marrow lymphoma, or what is your approach for such cases?
I'm not sure to understand well. So your question is?
How to?
Can you repeat slowly? Can you repeat slowly?
Yeah. So my question is how to approach a case of primary bone marrow lymphoma where the trephined biopsy shows in small size lymphoid infiltrates, which are just CD20 positive, and on immunophenotyping, they are negative for CD5, CD10. That is, we have excluded CLL, mantle cell, and it's just a low grade thing. And the molecular studies are negative, and there is no evidence of extramedullary disease in the spleen or the liver. So just a disease restricted to the bone marrow. So
okay.
Label
so it's not usual to have this kind of lymphomas. Usually you have peripheral blood involvement, but the most frequent diagnosis in cases that have this infiltration with expression of BCL marker, but in absence of CD5, CD23, and CD10, you should always think to splenic marginal zone lymphomas, even in the absence of a spleen. And in that situation, you should look at always to the pattern of bone marrow infiltration, and especially to the whether there is a sinusoidal pattern of infiltration, because the infiltration sinusoidal is rather characteristic of splenic marginal zone lymphoma.
Thank you. Thank you.
Thank you. Any other question from anybody?
Sir, I have one question.
Yes, Akshay.
Thank you, sir, for your time and the wonderful presentation. Sir, I just wanted to ask one thing, that what was the thought process or the rationale behind introduction of the term splenic B-cell leukemia lymphoma with prominent nucleoli and inclusion of hairy cell variant cases and some cases of BPLL in this category?
Yeah. Do you want me to clarify this issue?
Yes.
Yeah, okay. So the B-cell lymphocytic leukemia, hairy cell leukemia variant are classified in ICC as well in the WHO 216 as distinct entities. So B-cell lymphocytic leukemia is a distinct entity, and hairy cell leukemia variant is a provisional entity in ICC. Now, these two terms in the WHO 5th edition classification disappear because the hairy cell leukemia variant and the B-cell lymphocytic leukemia are named splenic B-cell lymphoma with prominent nucleolus. This is a heterogeneous category that includes a number of entities, that is B-cell lymphocytic leukemia, hairy cell leukemia variant, some cases of unrecognized, undiagnosed leukemic mantle cell lymphomas, and also cases of progressed B-cell chronic lymphocytic leukemia. Is that clear?
Okay, thank you, sir.
Okay.
Thank you, Dr. Akshay, for that wonderful question. Please, others, your difficulties, your questions. Yes, Dr. Parivar.
Sir, my question is related to mantle cell lymphoma. Whether we have to do TP53 mutation in conventional variant of mantle cell lymphoma, or where there is no other high grade features are present, or we have to do each and every cases of mantle cell lymphoma.
So, as you know, the WHO classification comprises three different forms of mantle cell lymphoma. In situ mantle cell lymphoma, which is that you diagnosed only by morphology and by immunohistochemistry. So that there is a single lymph node, and when you look at the lymph node, surprisingly, you find that the mantle cells are cyclin D1 positive because there is a localized mantle cell lymphoma. Then you have another entity, which is the conventional or classic mantle cell lymphoma. And then you have the entity, which is so-called non-nodal leukemic mantle cell lymphoma, okay? So as far as it concerns the classic conventional mantle cell lymphoma, the P53 mutations and deletions should be always searched in this lymphoma because together with the proliferative index, that is the number of Ki67 positive cells, more than 30%, represent two important prognostic factors which are included in the classification schemes of mantle cell lymphomas. Moreover, this is clinically useful because to have P53 mutations is when you treat a patient, the prognosis of the patient is much worse than patients that do not have a P53 mutation. And the probability to find a P53 mutation or deletion is much higher in the classic variant of mantle cell lymphoma, especially so-called pleomorphic and blastoid morphology, than in the non-nodal leukemic mantle cell lymphoma, which is usually characterized by absence of TP53 mutations, absence of ATM mutations, and small cell morphology, indolent course, leukemic involvement and large splenomegaly. In that situation, does not mean that during the course of the disease, a non-nodal leukemic mantle cell lymphoma does not acquire an TP53 mutation. This is the rule. After 3-4 years or after chemotherapy, there is a selection of TP53 positive cells, and a non-nodal leukemic mantle cell lymphoma can transform into nodal TP53 or ATM mutated classic mantle cell lymphoma.
Sir, one more question, that in a case of relapsed diffuse large B-cell lymphoma, whether it is important to do the cell of origin in a relapsed case of DLBCL?
Okay, so it is important in general, more than repeat the cell of origin in a diffuse large B-cell lymphoma. It is important to perform immunohistochemistry that all gives information not only about cell of origin, but about the type, the kind of antigen that are expressed in the diffuse large B-cell lymphoma. Because in the era of CAR T cells, you need to know whether when you are in front of a refractory relapsed large diffuse large B-cell lymphoma patient who is a candidate for CAR T cell therapy, whether the CD19 molecule is expressed or not. Because some lymphomas over the time can lose the expression of B-cell antigens, such as CD19, especially plasmablastic lymphoma that usually do not have B-cell antigens. So it is important always to repeat a biopsy if the patient, especially if the patient is candidate for CAR T cell therapy, or if is eligible for a clinical trial where you use lenalidomide or ibrutinib, which are usually targeting ABC lymphomas, which the cell of origin is important.
Thank you, sir.
Thank you, Parimar. Dr. Udyan.
Good morning, sir. Thanks for the nice lecture. My question is regarding a situation where in bone marrow study you get extensive plasmacytic population. Now, in that situation, when you are not sure whether to call it marginal zone lymphoma with extensive plasmacytic differentiation, or a myeloma, or if I can add a lymphoplasmacytic lymphoma. So what is the easiest way to distinguish between these three? That is question number one. And question number two, in case we are equivocal on the pathology side, then how the case should be treated as? That is the second question.
Okay, so you have several situations in which there is the prominent to distinguish various conditions with plasmacytic differentiation, both in nodal and bone marrow sites. So one is lymphoplasmacytic lymphoma. Lymphoplasmacytic lymphoma, you can differentiate lymphoplasmacytic lymphoma. You must differentiate lymphoplasmacytic lymphoma from marginal zone lymphoma with plasmacytic differentiation. This is the most difficult differential diagnosis, both in nodal and extranodal sites. The way to distinguish this condition is to perform molecular studies for MYD88 mutations. MYD88 is present in about 90% of lymphoplasmacytic / Waldenström macroglobulinemia, while it is absent in marginal zone lymphoma with the plasmacytic differentiation. The second markers that you can use is IRTA1. IRTA1 is a marker of marginal zone B cells in normal tissues. You can do immunostaining for this marker. And this marker is positive in marginal zone lymphoma with plasmacytic differentiation, but is negative in lymphoplasmacytic lymphoma, Waldenstrom macroglobulinemia. Okay. The differentiation of multiple myeloma usually is not with lymphoplasmacytic lymphoma. Usually in the bone marrow is usually not a problem because because of the morphological pattern. In lymphoplasmacytic lymphoma, you have a more heterogeneous polymorphic pattern. You have a plasma cell together with small lymphocytes, lymphoplasmacytic lymphocytes, whilst in myeloma, you have a more monotonous pattern, only plasma cells. In addition, in multiple myeloma, MYD88 mutation is absent, and multiple myeloma has additional chromosomal abnormalities that can recognize that are absent in lymphoplasmacytic lymphoma, which is in turn MYD88 positive. So the diagnosis is not so difficult.
Okay, thank you very much, sir.
So I don't think there are overlapping cases that where you have the problem of how to treat the patient.
Thank you.
Thank you.
Dr. Amrita Saraf.
Thank you, sir. Hello, everyone. It's a very wonderful talk. And my question here is, like, it was discussed that in all the high-grade B-cell lymphomas, it is mandatory to do make BCL2 and BCL6. And in case there is, my question is like, should we do TDT also in all these cases in addition to these three important markers? And the second part of the question is like Dr. Fellini has very well clarified that there is a separate entity which is like high-grade B-cell lymphoma expressing TDT, but it is not mentioned in this fifth edition. So according to this protocol, that should also be a part of the classification.
Okay, so I would recommend that TDT is performed in all high-grade B-cell lymphomas. If you find expression of TDT, in these cases, this case should not classified anymore as lymphoblastic lymphomas. This case should be classified as high-grade B-cell lymphoma expressing TDT. This is just a note in the report, but the treatment should be as for high-grade B-cell lymphomas, not for lymphoblastic lymphomas. And this is true both for the ICC and the WHO 5th edition classification. This is a very difficult issue. Recently, I saw a patient with high-grade B-cell lymphoma, which was in which it was high-grade B-cell lymphoma from the heart. It was cardiac, high-grade B-cell lymphoma, so all the cells expressing TDT. And this was the final diagnosis, high-grade B-cell lymphoma with TDT expression. But the difference diagnosis was, of course, toward lymphoblastic lymphomas. In this situation, also immunostaining for CD34 should be performed.
Definitely, I agree. Thank you so much.
Yeah.
Thank you. Amrita, you had another question also.
That is, I think he has already mentioned that there should be a category, and it's like I saw that it is not there in this 5th edition. So this ideally should be there since they are being treated as lymphoma, not as leukemia, or immaturity markers should be done. Thank you, sir.
Okay, thank you. There's a question from Dr. Rajani Priya from the audience. Is the classification for pediatric lymphoma same as adults? And if not, then how best to classify the pediatric lymphomas?
The classification of lymphomas of pediatric lymphoma is not different from the classification in children and adults. Is the same. There is no difference. Of course, as you know, there are some categories that are particularly frequent in children. Most of the lymphomas in children are aggressive lymphomas, you know, usually diffuse large B-cell lymphoma or high-grade B-cell lymphomas or lymphoblastic lymphomas. Low-grade B-cell lymphomas very rare in children. And follicular lymphomas, as you know, are very rare. So in general, low-grade B-cell lymphomas very rare in children.
Right. Any more questions from the audience? Yeah, Dr. Jay.
Yeah, hello, sir. So this question was, is there any point in doing a P53, say by immunohistochemistry for large cell lymphomas? A lot of recommendation on doing that of late.
There is no recommendation in terms of diagnostic criteria. So it doesn't change our diagnosis to do P53. As you know, as I have shown, there is a category of diffuse large B-cell lymphoma, molecular category, which is characterized by P53 mutations and deletion, which is associated with the worst prognosis. But as you know, the ICC and WHO do not regard a prognostic factor as a category. You see what I mean? Prognostic factor is something that can be added to the report, but it's just a prognostic factor. So at this moment, these lymphomas, if they are P53 positive, do not change our diagnostic criteria.
Okay, thank you.
Thank you. Any more questions?
Sir, one question.
Yes, Parimal.
Sir, my question is that we should have to do IBER-ish for each and every cases of diffuse large B-cell lymphoma.
I would suggest that not in every B-cell lymphomas, but in many B-cell lymphoma, you should look for IBV, especially in older patients, because as you know, you have this category of diffuse EBV positive diffuse large B-cell lymphoma in elderly. And this can help to classify the disorder, and some effusion B-cell lymphoma may be EBV positive, and this should be done. In other circumstances, to perform IBER is not necessary, but there are some circumstances in which I would recommend to perform IBER.
Thank you, sir.
Thank you. Any more questions? So there is one question again from the audience. Dr. Ashok Rajoria, high-grade B-cell lymphoma in leukemic presentation, which is not lymphoblastic. How to further subclassify it?
The classification is the same. I mean, just it doesn't. The only thing is that is changed is that there is leukemic involvement, but the leukemic involvement that does not change the diagnosis. If the diagnosis high-grade B-cell lymphoma is just high-grade B-cell lymphoma with leukemic involvement.
Right. If there are no more questions, there are two comments, sir. One is excellent talk. Thank you very much for simplifying the updates on mature B-cell lymphoma. In future, please cover T-cell lymphomas as well.
I will.
Thank you, sir. And
it was too long to include also T-cell lymphoma.
Yeah, we'll keep it as a separate talk, and you will oblige us, I'm sure. Yeah. The second is a very interesting remark. What is the secret of your physical and mental agility? Listening to you, we feel that we have got Alzheimer's. So
I don't know. the secret is the passion. The passion I have for the work I'm doing.
Absolutely. It's the passion which keeps you going on. Fantastic.
Yeah.
So I think so that these are the questions. Those are the remarks. I'm extremely grateful to you once again for being with us. What a fantastic talk you gave and made us realize and humbled us with our knowledge. Thank you so much, sir.
Thank you, Dr. Agarwal. Thank you.
Thank you.
Everybody.
Thank you so much.
And we have an official vote of thanks from Mr. Sumit Kumar Madan from ZS.
Okay. Bye-bye.
Yes, sir.
Bye.
Oh, Sumit.
Yeah. Thank you, Professor Falini, for sparing your valuable time on this Sunday and joining us for this webinar. It was a lucid presentation and we have many key takeaways from your presentation. Thank you so much for imparting your valuable knowledge and keeping us abreast of all the new updates on classification of mature B-cell lymphomas. On behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.B. Agarwal, for providing us this wonderful opportunity and making us a part of this elite academic discussion. I also thank all the discussants and participants who have joined us for this webinar. Thank you so much and have a lovely weekend. Thank you.
Thanks to Professor Amanji Bal also for inaugurating our webinar and the Perfect Square for managing the show absolutely flawlessly. Thank you and a wonderful.
Okay. Bye-bye.
Bye-bye.